All right, so welcome to week 4. So the chapters for this week are chapters 4, 29, and 30. So we'll start with chapter 4. Chapter 4 is government, the law, and policy activism. Chapter 29 is the faith community nurse, and chapter 30 is the nurse in public health, home health, palliative care, and hospice. So chapter 4 is all about government, the law, policy activism. So a little bit about, the structure of the government, healthcare roles, the key functions of the key governmental agencies that will affect health systems and nursings. We'll, look at some of the key terms related to policy and politics, and the relationship between nursing practice, health policy, and politics. So when we look at the community health nurse, those that, wish to work in the community as their area of practice, need to be aware of the impact of government, of law, health policy, on nursing, health, and the communities in which you guys are going, that the nurse will practice in. And so, it's also good to know how the government law and political action have changed over time and, what has caused the changes within healthcare because of that. And we know that nurses, no matter where you're working, whether it's in the community or even in a facility, right, we are advocates for the healthcare of our patients. And so that is, understanding how, the agencies, the healthcare laws, the policy process, and all of those things fall into place, help us to advocate better for our patients. So there are some key terms that we need to look at. And so policy, what's a policy? So policy is a settled course of action. It could be a law, regulation, or a voluntary practice to be followed by a government or an institution to obtain a desired end. Public policy is described as all governmental activities, direct or indirect, that influence the lives of all citizens. Health policy is a set course of action to obtain a desired health outcome for the individual, family, group, community, or society. Policies are made not only by governments, but also by institutions like a health department or other healthcare agency, a family, a community, or even a professional organization. And politics, right? That's just the art of influencing others to accept a specific course of action. And a law is a system of privileges and processes by which people solve problems based on a set of established rules. It is intended to minimize the use of force. So just some overview of some definitions. And so we look at the government, there's three, branches of government. The executive branch is the one that suggests, administers, regulates policy. That consists of the president, the U.S. Department of Health and Human Services. We had the legislative branch. The role of that branch is to identify problems, propose, debate, pass, and modify laws to address whatever the problem was that they identified. And it's Congress at the federal level, which is, broken into the Senate and the House of Representatives. Then we have the judicial branch. The judicial branch interprets the laws and their meaning. It is, the power of the police. And so state power concerning healthcare is called police power, that allows states to act to protect the health, safety, and welfare of the citizens. So there's, different parts of the branches of government. When we look at, trends and shifts, in governmental roles, there's a lot of things that, were cause of that. Um, Wars, economics, political differences, all of those things help to shape the government's role. And so, we do have some government agencies and acts that are specific for health. Um, and so we have like the Public Health Service, we have the Social Security Act, the National Institute of Health was created under the government, Medicare and Medicaid programs. Of course, the Affordable Care Act is another one, of the acts that was created for public health care. The functions of the government healthcare, they do provide direct services. Some of the direct services, healthcare to members and dependents of the military, veterans, federal prisoners, state and local governments also employ nurses to deliver a variety of services. Especially like if there is a particular service that is needed. We have financing. So the financing, we have the government financing, like your Medicare, your Medicaid, your Social Security, your state child health programs. The federal government also invests in research and new program demonstrations. The National Institute of Nursing Research is part of the National Institute of Health. It provides some money to the discipline of nursing for developing knowledge base of nursing, promoting nursing services in healthcare. It also provide the government healthcare also or functions also provides information, collecting vital statistics, morbidity and mortality information, census data, healthcare status surveys, that kind of thing. Policy setting, we know that, governments at all levels and all branches make policy decisions about healthcare. And those, decisions have implications for financial expenses, resource use, delivery system changes, as well as innovations within the healthcare field. And then, of course, public protection. So the Constitution gives the federal government the authority to provide for the protection of the public health. So things like, regulating air and water quality, protecting the borders from the influx of disease, controlling food, drugs, and animal transportation. Um, so there's a variety of things. And then we have our wonderful Healthy People. Healthy People 2030 is another one of the examples of our national health policy guidance. And so this started in 1979, the Surgeon General issued a report that began a 20-year focus on promoting health and preventing disease for all Americans. So Healthy People 2000 came out in 1989, I think it was. And throughout the 90s, we used the Healthy People 2000. Then of course we had Healthy People 2020, and now of course we have our Healthy People 2030, which has been a focus of this course since the beginning. So if you need to go back and look at those sites about the Healthy People 2030. We have international organizations as well, like your World Health Organization. The World Health Organization was established, back in the late 40s. And it provides, services worldwide to promote health. It also cooperates with member countries in promoting health efforts. It also disseminates biomedical research. So there's a lot of information if you are ever looking for research. The World Health Organization website is another good one. Federal health agencies. Um, we have the U.S. Department of Health and Human Services. That is the agency that is most heavily involved with the health and welfare in the United States. Um, we have the Health Resources and Service Administration. It offers programs and services, and it offers health professions education. Um, We also have the Centers for Disease Control and Prevention. It's the national focus for developing and applying disease prevention and control, environmental health, health promotion, education activities, all designed to improve the health of the people within the United States. Um, it's, the CDC became, a lot of people, I mean, everybody knows about the CDC, but especially during COVID, with that COVID outbreak, they were really at the forefront. Other things they do, they help to provide health security, to detect and investigate health threats. They're looking at the biggest health problems that cause death and disability. They conduct research. They also, look to promote healthy and safe behaviors, communities, and environments. They develop leaders, train public health force, implement prevention strategies. Um, so the World Health or the Centers for Disease Control and Prevention is another really good resource when you're looking at, things that are going on, whether it's, locally or even globally. They have a lot of great information that is, available to you. The Agency for Healthcare Research and Quality is the lead federal agency charged with improving the quality, safety, efficiency, and effectiveness of healthcare for all Americans. It supports health services research to improve quality of health, provide evidence-based decision-making. We have the Centers for Medicare and Medicaid Services, CMS, anybody that's worked within a healthcare organization has heard about CMS. Medicare and Medicaid are your federally funded healthcare health insurance, I guess, or healthcare programs within the United States. But they also, perform quality-focused healthcare, health-related activities, like regulation of lab testing, coverage policies, improving quality of care. They, also maintain oversight of surveying and certifying of nursing homes, and continuing care providers like home health agencies. It also, and it's pretty, the CMS is a pretty vast organization. And then there's some other, governmental agencies like the Department of Defense, the Department of Labor and Agriculture, the Department of Justice, all of these that provide healthcare to a variety of constituents or variety of patients, I should say. And then we have our state and local health departments. So programs that are offered by state and local health departments are going to vary depending on funding, as well as public commitment and interest. So there is a variety. So I'm just going to use my local public or health department. We have a really large area, and our health department covers four cities and 2 counties. So it's a pretty large gap. They have one main health department, and then they do have satellite areas in some of the smaller areas, and not each of those smaller buildings offer the same services. And in the period of time that I've been here, they've had significant changes with the services that they have offered with the health department. So initially 25 years ago, we had an epidemiologist. We also had, disease outreach. So newly diagnosed diabetics that were being discharged, especially in some of our underserved areas. There was a diabetic educator that would do home visits just to check up on them to make sure that they, understand their, regarding their disease process, like, how to check their blood sugars, how to give their insulin injections, what to do if they're sick, those kinds of things. Um, and since, over time, because of lack of funding and things like that, we don't have the diabetic educator. They still offer, the STI testing. They do offer some immunizations, but it's not like it used to be, just because of the local or just because of lack of funding. They do also, and it might be different in other states and areas, but they also have something called here, it's called the Medical Reserve Corps. And it's a voluntary program. They accept anyone, licensed nurses, doctors, veterinarians, and it's just, um, it's another outreach program. So I was a member for many years. If there's a hurricane, we'll go and help to man the shelters. If they're going to have like, um, what is it, like a health fair, or even like if they're going to have free veterinarian services, we'll just go out and, help whatever we can do. If there's an outbreak, like COVID, or, many years ago, probably about 10 or 15 years ago, we had an outbreak of salmonella. So it would also be something that, volunteer, that we could do to assist. We've also, we would go out to some of the um, older apartment complexes, not assisted living. These are all independent, apartment complexes. And we would do blood pressure checks and just check in on some of the older people who, really couldn't get out of their house. And so I would go every 2 weeks. They would all meet me in a common area, and we would do blood pressure checks, and we would just talk and see if there was anything, any resources that they needed, things like that. But like I said, and that's all a voluntary basis. And so it's a little bit hard sometimes, when people have work and, school, things like that. But they're always looking for volunteers to go and assist the underserved populations. Another big thing that we, when we talk about, the, different types of law. Um, and so a law is just a system of privileges and processes by which people solve problems on the basis of a set of established rules, right? And so the goal here is to minimize the use of force. After a law is established, the regulations define the course of actions to be taken by the government, organizations, or even individuals, in reaching an agreed upon outcome. And so government and its laws are the ultimate authority in society, right? And so we have constitutional law. Constitutional law, it derives from federal and state constitution. It's an overall guidance for selective practice. So, things like what can, the states do, what they cannot do. Some of it is, open to interpretation as well. Legislation is law that comes from the legislative branches of the federal, state, or local government. It is referred to statute law because it comes coded in the statute of the government. Regulations are specific statements of law related to defining or implanting individual pieces of legislation or statute law. So state legislators enact laws establishing like boards of nursing, and, defining the terms like a registered nurse or even nursing practice. And the board may be found either in the Department of Licensing Boards of the Health Department or in an administrative agency. So one of the big things here is your State Nurse Practice Act. And so the state boards of nursing are what establish your Nurse Practice Act. The state boards operationalize, implement, and enforce the statutory law by writing explicit statements on what it means to be a registered nurse, and on the nurse's rights and responsibilities, and delegating work to others, and meeting, of course, our continuing education requirements. And so, no matter what state you are in, you are going to have a Nurse Practice Act. And it is super important that you understand what you can and what you cannot do as a licensed nurse. And it's just not registered nurses, it's your certified nursing assistants, it's your practical nurses as well. And it will outline what you can and what you cannot do. So no matter where you go, you will have a Nurse Practice Act. One thing that's really important to know too is even with these compact licenses, compact licensure means that you can practice in other states with your nursing license. And it's still your responsibility to make sure that you know what that Nurse Practice Act is. So let's say you get licensed in North Carolina, you are all under, the North Carolina Board of Nursing, right? But then you get a job in, let's say, South Carolina. Even though you're licensed in North Carolina under a compact license, you still have to understand what the Nurse Practice Act is in South Carolina to make sure that you do not violate any of those regulations. And then, depending on where you work, you're going to also have to comply with other, rules and regulations. So, if you're working with Medicare or Medicaid patients, you have to understand the legislation and regulations regarding your Medicare and Medicaid. We're also, private and public health care services. We're also, responsible for quality of care, the standards of documentation, confidentiality, communication. So again, I'm going to let you always look back at your Nurse Practice Act and whatever the laws and regulations governing the practice that in the area that you are working with. Your scope of practice. The issue of scope of practice involves defining nursing, setting its credentials, and then distinguishing, between the practices of nurses, physicians, and other healthcare providers. And so again, you are subject to the laws of the state in which you practice. And if you are going to practice outside of that state, you have to understand what the laws are in the state that you are going to be working in. The Nurse Practice Act accomplishes 4 functions. It defines the practice of professional nursing, identifies the scope of nursing practice, setting educational qualifications, and then other requirements for licensure, as well as determining the legal title of nurses may use to identify themselves. And then it can describe, determine, refine the scope of practice of a professional nurse. So, what is negligence? Professional negligence or malpractice is an act or a failure to act that leads to injury of a client. To recover money damages in a malpractice action, the client must prove all of the following. The nurse owed a duty to the client and was responsible for the client's care. The duty to act the way a reasonable, prudent nurse would act in the same circumstances was not fulfilled. Reasonably under the circumstances led or the injuries provided the basis for a monetary claim from the nurse as compensation for the injury. And so, when a nurse is employed and is functioning within their scope of employment, the employer is ultimately responsible for the nurse's negligent actions. And that's something that you have to be aware. It is, very, what's the word I'm looking for? Widely encouraged that you do maintain your own professional liability insurance. As students, the American Nurses Association does offer discounted rates for, I want to say it's like up to a year, but it is recommended that nurses do have their own liability insurance just to protect you. Most organizations will tell you that they will protect you while you are, working there. However, it is always best to have something, else to fall back on. Um, when we look at legal issues that affect healthcare process or practices, when we look at health departments or boards of education, when we're looking at school and family health, school health, there's a minimum of services that must be provided to children in public and private schools, right? They have to be immunized before going into school. They have to have a physical, what type of health screening should be conducted in the schools. So like here we do, it's not every year. I think it's like every other year, every 3 years. They'll do height, weight, vision and hearing exams within the school. In some of our areas, they offer free dentists. The dentist will come to the school to see what's going on. And then, of course, make the referral to another dentist if there is something that needs to be taken care of. We as nurses are mandatory reporters. And so, working within the school systems, if there is a child that we suspect is being abused or neglected, you need to, of course, follow the appropriate chain of command to make the appropriate referrals because we are mandatory reporters. Occupational health is another area of practice that has pretty specific legal requirements. Um, and occupational health, that's your workers' compensation statutes. It just really depends on where you're working. So like my daughter, she's an RN, she works in Ogg Health. And a majority of what they do is pre-employment screening, and then maintaining like yearly updates. So they do making sure that they're okay to work, that they have their immunizations, that they're immune, or if they refuse their immunizations, that kind of thing. They'll do like the respirator fit tests, the annual flu vaccines. And then, they have to come in or everyone has to come in and do like a yearly visit with them, just to keep everything up to date. And then, they each, will look at other areas within the healthcare system, like correctional health. Anybody who wants to work in a prison or a jail, they do have healthcare services that are provided with them. So, and then the level of care that they require is going to depend on, what disease processes that they have. My mom was a correctional nurse. She worked at a state prison in Florida. And so a lot of it was, managing some of their chronic illnesses. They had, quite a few HIV patients, but even things like hypertension, diabetes, and then, of course, if there's any emergency situations that arise as well, within within the prison. Of course, she would have to become involved with that. Um, but when we look at our role as nurses and the policy um, process, and I'm sure you may have heard this before, but we need to be involved. We also need to understand the importance of involvement, so that we can better advocate for our patients and even for ourselves. So, we've heard, terms like um, patient nurse ratios, things, where can we, how do we become involved to make it safer for both ourselves as well as our patients? Working in the community, working in a facility or a hospital, about the healthcare problems that, encounter. And so, we as our, it is recommended that we become policy driven and advocate. So there's things like the State Nurses Association. There's also, the Association of Community Health Nursing, the Association of Public Health Nursing. These are at national or state levels. There's also say you don't want to be a community health nurse, you want to be, you want to go work in the NICU. Those, specialties have their own organizations that you can become involved with as well. So, there's organization for, the broad aspect, which is your State Nurses Association. And then there's there's federals. Um, and like I said, there's individual. So, med surg, neonatal, OB, psychiatric, whatever it is, whatever your passion is, that you want to, go whatever area of nursing that you want to go into, there's going to be a professional organization that you can be a member of. And it can be, just advocating, like I said, for yourself as well as for your patients. Whether it's making phone calls, writing letters, keeping yourself up to date on what's going on. Understand, it's always better to belong to some sort of an organization so that you are up to date with current healthcare practice, your evidence-based practice. You want to make sure that you are informed of what is going on. You should know who your elected officials are. You can become active within the State Nurses Association. It also will help to expand and strengthen your professional network. It helps to build relationships. Um, it allows you just to be, get that appropriate information as you, try to advocate for what's best for your, not just for your patients, but for us as well. Because there is a lot that goes on that, we don't always have a whole lot of control over. And so making sure that we have a voice can help to make nursing even better than it already is. So that brings us to chapter 29. So chapter 29 is the faith community nurse. So we'll talk about the role of the nurse in the faith community, holistic health promotion, disease prevention, spiritual care. We'll look at, the scope and standards of practice for the nurse within the faith community. And so nursing within the a faith community is defined by the American Nurses Association as a specialized practice of professional nursing that focus on the intentional care of the spirit, as well as the promotion of whole person health and the prevention or minimization of illness within the context of a faith community and the wider community. And so the faith community nurse balances knowledge and skill in the role and facilitates the faith community to become a caring place. They'll work with individuals, families, as well as groups. And so we have what our parish nurse was the initial term that was used. And I actually, one of the nurses that I used to work with a long time ago, she was actually a parish nurse as well. And is very active in the church and does a lot of home visits within, not just the elderly population within the parish, but, some of those that, may have kids with special needs, or, even some of your more chronic just disease processes. But the nurse in the faith community is a licensed registered nurse that has well-developed clinical and interpersonal skills, a strong personal religious faith, and a desire or a felt call to serve the needs of the faith community. And so the assumptions that underlie this specialty, health and illness are human experiences. Health is the integration of the spiritual, physical, psychological, and social aspect of the healthcare consumer to create a sense of harmony with self, others, the environment, and a higher power. Health may be experienced in the presence of disease or injury. The presence of illness does not preclude health, nor does optimal health preclude illness. And healing is the process of integrating the body, mind, and spirit to create wholeness, health, and a sense of well-being when the healthcare consumer's illness is not cured. We look at faith communities. Those are organizations of groups, families, and individuals who share common values, beliefs, religious doctrine, and faith practices that influence their lives. So whether it's a church, whether it's a homeless shelter, whether it's a temple, a mosque, they all function as a patient system, providing a setting for nursing practice. It just depends on, what area that you are working with. Health ministries are visible activities, programs, and rituals of faith organized around health and healing of the congregation's membership. And they're offered by the nurse, the clergy, a layperson, or even community resources. They can be either informal or they can be formal activities that are provided. According to the ANA, scope and standards for practice for all nurses, spiritual care is part of all nursing practice, and acknowledges a person's sense of meaning and purpose in life, which may or may not be expressed through formal religious beliefs and practices. And so, working, if you remember going through, was it health assessment? When we're looking at doing that full, admission assessment, that full complete head to toe, right? We look at spiritual care. What can we do to fulfill their spiritual needs while they are in our care? It helps the client to make meaning out of his or her experiences, help them to find hope. And spiritual care is different from religious care. Religious care, that stems from the doctrine, the rites, the rituals of a specific denomination or set of belief, whereas spiritual care is unique to the individual's purpose in life, the fulfilling of that purpose, and living it wholeheartedly. And so there is a difference in that. Holistic or whole person care. I know we've heard that term before. That's, the relationship between body, mind, and spirit in a constantly changing environment, and involves caring for the soul and a special kind of engagement that goes beyond seeing the physical patient, but includes observation of the entire patient, right? So, what is affecting that patient? Yes, we know that they have hypertension, or we know that they have diabetes, or we know that they have, you know, kidney failure, they're on dialysis. Um, but what else is going on with that patient? What are the outside influences? What is going on, you know, psychosocially, um, spiritually. We've heard of things like spiritual distress. And so I'll share a story with that. My mom, we were all, raised Catholic. My mom, as she got older, she, chose not to go to church. So she wasn't very religious where, she would go to church every Sunday. But she still remained very, I don't know, faithful, I guess, is the word for it. And as she got sick, and when we ended up having to put my mom into hospice care, one of the biggest things that when they sat down and they were talking to my mom about her spiritual needs, she was very adamant about having a member of the clergy come out, just to sit with her and talk to her, even if it was just once, or twice, once a week, or, even just a couple times, um, so that she, because that really did help her. Um, and, one of the biggest concerns that she had was, making sure that the priest would come and give last rites, which is, something it's it's a very big part of, the Catholic faith. Um, and I remember the day that she passed away, the priest had not come and given her last rites. And so I panicked, and had to call and try to get the priest to come and give her last rites, and he did. Um, but it was, we have to look at these things when we're taking care of our patients, because it is important to them. The a nurse within the faith community is a recognized nursing specialty practice. Um, the goal of, the faith community nurse is to establish close relationships with individuals, families, and, in some cases, the larger community, to coordinate programs and services that, affect health, healing, wholeness, balance knowledge and skill in their role to facilitate the faith community as it becomes a caring place, and address health concerns of individuals, families, and groups of all ages. Other terms, religiosity is a person's beliefs and behaviors associated with a specific religious tradition or denomination, where spirituality is an individual's attitudes and beliefs related to transcendence, or to the non-material forces of life and nature. So there is a significant difference between religiosity and spirituality. And so, working within the faith community, they may experience birth, they may experience death of both acute and chronic illnesses, stress, challenges from life transitions. They also, help to make decisions regarding healthy lifestyle choices. And so they can work within their faith community, um, for health promotion, as well as, assisting with those good, healthy life choices. And we know as nurses, regardless of where we are working, but especially in the community, we can provide the holistic community-based care, for both vulnerable and underserved populations. We also can collaborate with other healthcare providers. So think about, a group, a parish, you have a group of, or I'm just using a parish as an example, but whether it's a Catholic church, Protestant, Methodist, a mosque, a synagogue, whatever it is. You have a nurse. I'm sure there's, other healthcare providers and others within, the congregations that can assist. So, not only that, as nurses, we, have interactions with doctors and other members within the healthcare community. And so we can collaborate with other providers as well to provide that, holistic community-based care to to that population of people. And so the nurse in the faith community is still governed by the Nurse Practice Act of the state in which the nurse is practicing. And so we can, look at the scope and practice of nursing through the American Nursing Association. There's also a faith community nursing scope and standard of practice. And there's also the American Nurses Association Code of Ethics with interpretive statements for nurses. So again, it's super important that they understand what their scope of practice is, so that they don't violate their Nurse Practice Act. They know what they can do and what they can do. In order to, become a nurse in the faith community, they must have an active registered nursing license, whether it's a diploma or associate degree. A bachelor's degree is preferred. They also need to complete educational course to prepare for the nursing specialty practice. They should have experience in public and population health, specialized knowledge of spiritual beliefs and practices in the faith community, reflection of personal spirituality, maturity, being organized, flexible, a self-starter, good communicator. And so the goals for a faith community nurse, protection, promotion, and optimization of health and abilities of the congregants, the prevention of illness and injury, and facilitation of healing. The nurse works to alleviate suffering through diagnosis, referral, and treatment. Advocate for all persons in the context of the values, beliefs, and practices of the congregation. So the spiritual dimension is central to the practice of parish nursing. The roots of the role balance both knowledge and skills of nursing, the humanities, as well as theology. And so the nurse, will combine nursing functions with pastoral care functions. So they may have visits in the office, the home, the hospital, or the nursing home, for prayer. And so, it's really important to understand the values and belief of the faith community in order to provide the supportive care. The focus of the specialty is the faith community and its ministry. Partnerships may be among individuals, groups, and healthcare professionals within the congregation. In some cases, even outside of the congregation. The services of the nurse emphasize strengths of families, individuals, and communities. And then health, spiritual health, and healing are considered ongoing dynamic process, very similar to your nursing process. So nurse interventions and programs used in the faith community, those faith community nurses provide care to individuals, families, and populations across life, regardless of ethnicity, lifestyle, gender, sexual orientation, or creed. The practice includes the culture of the population and geographic community, identify the health needs of the congregation. And so it is, incorporating faith and health using that nursing process. One of the first tasks of a nurse is to explore the social demographics, identify the health needs of the congregation. And so, doing just a health survey, whether online or in, printed, however it is. Um, and also do a resource assessment, to look at, what resources are needed, what resources are available, which of the available resources are accessible to the nurse. Can the work of the project or program be accomplished with what's available and accessible? Um, Nurses, within the faith, they can organize health fairs, invite community partners and other service agencies. Um, they can also, like within the hospital and institutions, they can visit, provide spiritual and emotional support when unexpected illness and health crisis arise. They can help them with coping skills, just provide, someone to be there with them. Um, and so, of course, just like anything, there are specific issues that, will arise within, community health nurses, um, conflicts. Um, So, the nurse and the faith community must be alert to issues of accountability to the population that they're served, as well as to those who entrust the nurse with the responsibility. And so the nurse will need to review, understand, and apply all professional parameters. So some of the potential for conflicts can be reduced by negotiations with the pastoral staff, congregations, institutions, and wider community must be involved in job description preparation and program planning. Provision of care for individuals and groups is documented and remains confidential. Issues such as privacy, confidentiality, group concerns, access, record management must be discussed with the pastoral staff at the outset of any program, and discussions of health promotion activities may include the individual, family, and leadership within the faith community. Um, and of course, now we do have our Healthy People 2030. With Healthy People 2030, it encourages communities to cooperatively lend support to individuals and families to attain an improved health status that can be passed on to future generations. Faith communities offer an ideal setting for health promotion and have long held positions of esteem and influence in communities, and where strong partnerships can be established with the healthcare institutions and communication and community agencies. Um, the older adults are one of the fastest growing age group in the community, right? So your baby boomer generation, everybody's heard of the baby boomer generation. So they were the largest generation, but they had the least amount of children. So quite a few, there's going to be a lot of them, but they didn't have children. Like I'm not a baby boomer, but my generation, right? We had more children than, for the most part, than the baby boomers did. And so there's going to be an increased need in dealing with that population. And if you look, there's a shortage, or we foresee a shortage, there is a shortage of geriatric providers, whether it's geriatric nurses, geriatric nurse practitioners, or geriatricians. There is, not enough at this time. And so that within a faith community, and the large numbers of adult, there's going to be some challenges. How do we improve the health and well-being of that population? And so objectives related to older adult health and faith communities under Healthy People 2030. Increase the proportion of older adults with physical or cognitive health problems who get physical activity. Reduce the proportion of older adults who use inappropriate medications. So that's your polypharmacy. There's a big push now to reduce the number of medications that the older population are taking. Do they really need to take 20 pills every morning, right? What can we do to reduce the number of medications that they're taking? It's really taking, it's providers taking a real deep dive into their medication list to see, if it's truly necessary. We want to reduce the rate of emergency department visits due to falls among older adults. So what are some things that we can do to help prevent falls? Community health nurses, nurses and these faith community nurses, looking in their, going into their homes when they're making their visits, looking at some of the safety concerns that may be present, and, identifying ways that we, potentially remove the hazards. Reduce the rate of pressure ulcer related hospital admissions among older adults. That goes back to your, basic nursing care. How do we reduce the risk for pressure areas? How do we prevent pressure areas? If older people are living alone and they have mobility issues, what are some things that's community outreach, or even a faith community nurse, what are some things that they can do to maybe help reduce that, pressure ulcer, or, some things that we can do to reduce the risk for pressure ulcers. Also want to reduce the rate of hospital admissions for diabetes among older adults. This is a big part. You can look at the cost of insulin. Insulin is very expensive, and I know that they're working on that. But when we look at the older population and their income, many of our older people are on fixed incomes, and many have to make the decision whether or not to buy medications or buy food. Which do they do? And so how do we go and ensure that they have their medications, that they're using their medications appropriately? I once took care of a couple who both ended up in the hospital together. They were both had hypertension. And I forget what medication they were on, but they couldn't afford to get both prescriptions filled, and they were on the same medication. And so they decided to split. The husband would take a dose one day and then the wife would take the dose the next day. Of course, that's not effective. And so they both ended up in the hospital. So what are some things that we can do to try to assist them? Reduce the rate of hospital admissions for pneumonia among older adults, and then reduce the rate of hospital admissions for urinary tract infections among older adults. And that's another huge issue, no matter where you work. Depending on, depending on where the person, I know, mobility decreases as we get older, right? Our kidney function decreases as we get older, just as general decline. Our bladder capacity, we may lose some sphincter control. We may not be drinking enough as we get older, and even some cognitive decline. So when we talk to older people, right, I remember this one lady was like, I am not drinking any more water. She was said, because every time I drink water, then I have to get up and go to the bathroom, and it's too hard to get up out of this chair every, 15 minutes to go use the bathroom. And so she would basically, what she was telling me, she was going to drink the minimum amount so that she didn't have to get up to use the bathroom as frequently. Which is not good for kidney or bladder health, right? But your older women, if they've had a few kids, and, they have some, urinary incontinence, that can also be an issue. With men, we look at enlarged prostates, and the inability to initiate that stream of urine, or which can even lead to urinary retention, which then can lead to a urinary tract infection, which then we know can travel to the kidneys. They can develop urosepsis, all of those things. And so it's really important to, look and find some appropriate interventions for these populations to avoid some of these things. Chronic illnesses, can be managed very, well, not always easily, but they can be managed. And it's just making sure that they are managed appropriately. And that's where the faith community nurse can actually, or even just, a public health nurse or a community outreach nurse. What are some resources within the within that, specific community or the community at large? Maybe there's, even, we have, groups that come together during the day, or maybe there's individuals who are retired that, can go and make visits during the day, whether it's to, help prepare meals, to, remind somebody to turn and reposition. I was taking care of a younger lady. She was actually the victim of a gunshot, or she was victim of gun violence. I don't know why I say gunshot, but she was shot by a gun. She was a victim of gun violence. And so she is a paraplegic. Um, and she was living at home by herself, and has I'm gonna say unstageable. And the only reason why I'm gonna say unstageable is, if you initially look at it, it looks like a stage 4 pressure ulcer on her hip. Unstageable because she still has a lot of necrotic tissue within there and a lot of sloughing. But I can basically if I ball my hand into a fist, I can put my fist into her wound. And she was at home taking care of herself. Her daughter does come and visit on a daily basis. However, if you can't feel it because of the, of the paraplegia, it was, causing her to not turn and reposition like she should. So what are some things that, we could do for that patient? One thing that I had suggested to her was to set an alarm on her phone. And so set it for, if she's in bed, set it for, every hour just to offload. If she's in a chair or wheelchair, set, for every 15 minutes just to offload in a chair. Just some different things, and of course providing education to the family as well as the patient, making sure that their diet, that, of course she can't get up and walk. But that offloading is definitely key. Nutrition, hydration, even maybe some supplementation like Ensure, even the Carnation instant breakfast is good, right? What are some interventions that we can do to help, in that situation? Which then brings us to chapter 30. Chapter 30 is the nurse in public health, home health, palliative care, and hospice. So in chapter 30, we will talk about the different practice models for home and community-based services. We'll look at the roles and responsibilities of public health, home health, hospice, and palliative care nurses, differentiate the professional standards and educational requirements for nurses in public health, home health, hospice, and palliative care. We'll talk about the components of the Omaha system, how nurses in public health, home health, hospice, and palliative care use best practices, evidence-based practice, and quality improvement strategies to improve the care they provide. And we'll look at trends and opportunities in public health, home health, hospice, and palliative care involving technology, informatics, and telehealth. So public health, home health, hospice, and palliative care nursing are rapidly expanding. Um, Specialties under the broad umbrella of public health, community-oriented, and population-focused practice. So when nurses are practicing in these areas, they will provide comprehensive assessment, planning, intervention, evaluation, right, your nursing process. They contribute to the total health of the general public. Um, and so two additional nurse-led models are summarized as well. So we'll talk about nurse-family partnership, as well as transitional care. Um, so we'll look at some definitions as well, within this. Public health and, home health services. When we, let me start that again. So, um, public health, home health, hospice, palliative care, nursing are a wide variety of practice settings, and holistic services, that are provided to clients of all ages. Whether it's in their home, whether it's in a non-institutional setting, and even sometimes in institutional settings. So I worked, in long-term care facility, and we would have, hospice nurses that will come into our facility to provide hospice care. So it just really depends. But they can offer intermittent skilled supportive care treatments, or even assistance with ADLs. So that whether they're older, or, those that are ill or have other disabilities can remain safe, as well as avoid unnecessary, hospitalizations. Your hospice, your palliative care, services, those provide comfort. They meet physical, emotional, and spiritual needs to people of all ages. Um, Whereas hospice, usually is just your end of life, care. Palliative care is not limited to the days or weeks prior to the end of the life. And so palliative care can include curative treatments, whereas hospice care does not include curative treatments. Um, So other, whether with home health, hospice, and palliative care services, it's not just nurses. There's social workers, there's PT, there's OT, in some cases even speech therapy, home health aides, LPNs, chaplains. There's also physician services, and that is available as well. Um, the triple aim model for healthcare was published in 2008. And these are the foundation and core values of public health, home health, and related community-based services. And the goal is to improve the health of populations, enhance the experience of care for individuals, and reduce the per capita cost of healthcare. It encourages health promotion, prevention, healthier lifestyles, regardless of the program or setting. Even though we know that all illness, especially chronic illness, cannot be prevented or cured. Um, all right, so anytime a public health, home health, hospice, or palliative care nurse enters, a person's home or residence, um, the nurse is a guest, and will need to earn the trust of the family, establish a partnership with the client as well as the family. It is essential that clients and families are involved in making decisions for the home-based services, so that they can be effective and efficient. Um, and so family is defined by the individual client and includes any caregiver or significant other who assists the client with care at home. So when we look at family caregiving, that's your transportation, helping clients meet their basic needs, providing care, whether it's ADLs, meal preps, medication administration, as well as both simple and complex treatments. So, if we look at what the trend in healthcare has been, we can provide a lot of our complex medical care at home. It doesn't need to be in an institution, or even a long-term care facility, right? We can do IVs at home, we can do trachs, um, tube feedings, so a lot of the complex care that used to only be offered in an institution or a hospital, I should say, instead of an institution, such a better word, I guess. But we can provide a lot of this care at home, and so it does, in most cases, right, it allows that person to be more comfortable because they're within their own environment. Um, it can be confusing, it can be challenging, it can be stressful, especially for family caregivers. Um, it can be frightening. A lot of people are not prepared necessarily to, take care of a family member that has a complex medical condition. Right, learning how to use equipment, or even, how do you do a dressing change or give a tube feeding, all of that things, all of those things. And so, providing education to the family, and the client themselves, can help ease some of that burden. Also making sure that the family caregivers are taking care of themselves, to avoid caregiver burnout. Is also important as well, and providing resources. Resources are key, whether it's through the public health nurse, the hospice service, the home health service, whatever service it is, making sure that they have access to resources, should something happen, or even like, what do I do, situation like, oh my gosh, the IV pump has been beeping for hours and I can't figure it out, or the tube feeding pump isn't working, or the insulin pump, just decided to stop working. What are their resources that are available to the client as well as their family caregiver? So home health care is a pretty broad concept. It's an approach to services. It is right now on the list of the fastest growing service providing industries in this country. It focuses on primary, secondary, and tertiary prevention. The primary focus can involve, aggregate similar to those provided by other population focused nurses. But your initiatives for primary and secondary prevention are all, have always been important to home health care. So home health nursing is a specialty area of nursing practice that promotes optimal health and well-being for patients, their families, and caregivers within their homes and communities. They do use a holistic approach, with the, aims at empowering patients, families, and caregivers to achieve their highest levels of physical, functional, spiritual, and psychosocial health. They provide nursing services to patients of all ages, cultures, and all stages of health and illness, including end of life. And that's the American Nurses Association definition. So the home health nurse includes generalist nurse, public health nurses, clinical nurse specialists, nurse practitioners. And they and their interprofessional team provide diverse services to target populations, such as new parents, those that are recovering from injuries, acute illness, surgeries, frail elders, those managing disabilities, as well as chronic health problems. Some home health agencies also include wellness programs, health fairs, school nurses, communicable disease prevention, and other programs that are similar to those that would be offered by your public health departments. The home health nurse and the team help client and their families achieve improved health and independence in a safe environment. Again, depending on what they're eligible for, we can do physical therapy, occupational, speech therapy. We can provide, home health aides, medical social services, but skilled care, our skilled nursing and skilled nursing services are Medicare terms that describe the duties of the registered nurse. They refer to the requirement of professional nursing judgment, include diverse assessment, teaching, case management, and other interventions. Right, when we do the assessment, it involves environmental, psychosocial, physiologic, and concerns, and intervention as teaching, guidance, and counseling, treatment variety within, that home health. Um, when we look at hospice and palliative care, again, hospice and palliative care are very different. Very similar, but very different as well. And so some of the things that are similar between hospice care and palliative care, they're both client focused. They're both holistic. They both are going to rely on evidence-based practice. There's an emphasis on ethics, communication skills, interprofessional collaboration, care coordination. There's a focus on transition of care, as well as, the nurse needs to, provide caregiving skills as far as symptom management, pain relief, and comfort. The differences between palliative and hospice services are primarily related to reimbursement requirements, and include the length of care and frequency as well as intensity of services. Palliative care is a broad term. It's usually a longer period of time, where hospice services, right, are generally a short period of time. The goals of hospice and palliative care. So goal of hospice is to humanize the end of life experiences. So for hospice services, physicians need to indicate the clients have 6 months or fewer to live. And clients acknowledge that they have a terminal prognosis and select care that is comfortable, and not life extending. Whereas the goal of palliative care is quality of life, and the palliative care services are not restricted based on disease or disease progress. They can be appropriate for those that have a serious complex illness, regardless if, they're expected to recover fully, live with a chronic illness for an extended time, or experience serious disease progression. And so again, you can be in palliative care for a longer period of time, whereas with hospice care, it's usually they have a 6-month prognosis. Hospice focuses on comfort for individuals and their families at end of life, and does not include curative treatment. So that is, one of the biggest differences as well. Sorry. And, hospice is formalized, funded program. They also, and again, hospice is from, it can occur at any time during a person's life. Clients and their families are at the center of the hospice and palliative care teams. So they are going to be involved in the advanced care planning, the symptom and medication management, the personal care, the use of supplies. Bereavement services are also part of hospice care. And so, they may even attend the funeral or other services for the deceased client. They may contact them at anniversaries of death, holidays, for up to, 13 months after the client's death. The hospice organizations usually will offer support group opportunities for families, or even just refer them to support groups in the area. And so, hospice, again, it is a formalized funded program in hospice home health agencies with extensive data. So, we have, here in this area, we have, right, our hospice services. So there's quite a few hospice agencies that provide for hospice care. We also have one that's very specific to children. It's called Edmark. Um, and when I worked in pediatrics, I worked with Edmark. Unfortunately, worked with Edmark. Edmark is a pediatric hospice agency that is local here. And so, they work with children that are terminal under the age of 18. And so we had a couple kids that had terminal illnesses that we had to collaborate with hospice for kids. I wholeheartedly believe in the hospice programs. I could not be a hospice nurse. I think that what they do is incredible and amazing. Um, Hospice is the only Medicare program or Medicare benefit that includes medications, medical equipment, 24/7 access to care, and support for family after death. And so when I remember when my mom went into hospice, um, and the first hospice nurse, my mom, for some reason, they didn't get along very well. And so they brought in a different nurse, and she was absolutely amazing. Um, and I had gone grocery shopping, it was Mother's Day, and gone grocery shopping, um, had taken some stuff. I had got my mom a dozen yellow roses because those were her favorite. And I go to put them in her room, and something about her just didn't look right. And she was unresponsive. And I knew that it wasn't going to be long. So I called the hospice nurse just to be like, hey, I don't think that, I think that she is going to pass today. And this hospice nurse came, and my mom didn't pass till, it was probably, it was late, like 11 o'clock at night, maybe 10 o'clock at night. Um, and she stayed the whole day. And I kept trying to tell her, like, it's okay, you can leave. Like, I know you have a family, it's Mother's Day. Like, I'm sure you want to be with your kids or your grandkids or whoever. And she said, no, that was her job, and she was going to stay with us until the end. And she did. Um, and I felt bad because I was like, you should be home with your family. Like, there's anything really that she could do there, but she was a support for myself and, my kids, and my brother. And so just having her there was helpful. But hospice nurses do wonderful things. Um, I don't handle death very well. So I don't think that I could, handle that part of it. As far as like the support part, I could probably do really well. It's that, when they transition, that is what, usually gets me. I am still that nurse after 25 years that when I have a patient die, I will be crying right next to the family. So, um, hospice programs are usually operated and staffed as independent entities or corporations. They may also be part of a larger organization. Medicare regulations and financial requirements also, right, just have something to do with how the hospice programs are set up. Then, hospice nurses have to be familiar with regulations and financial requirements. We have OASIS, which is the Outcomes and Assessment Information Set. That is primarily for your home health agencies, is not required for hospice programs. So that is a little bit different. But again, like I said, Medicare is going to provide the most funds for hospice services. When we look at home care of dying children, that's probably the hardest part. The needs of your dying child and their families are unique just because of the emotional impact, right? We don't expect the young to die, or, predecease their parents. And that's something that my mom always said. My mom said that you don't bury your children bury you. And so it's a lot different when you're dealing with a dying child. Um, and just like with an adult, though, the nurse needs to recognize the child's physical, cognitive, psychosocial, and spiritual development, as well as the family dynamics, the cultures, the spiritual beliefs. We still, they need to provide for appropriate pain management, assist the child and family to communicate, advocate for their needs in the community, provide case management, continuity of care. And again, the bereavement programs are also part of the hospice program. So those services are free to the family as well, even after the person passes. Transitional care is a set of actions designed to ensure the coordination and continuity of healthcare as clients transfer between different locations and different levels of care in the same communication or in the same location. So challenges to quality care, come from a lack of depth, accuracy, and timeliness of information received from the referring site, the need for the complex medication reconciliation, and then difficulties with communication and coordination. So, this is like let's say you have a patient that is being discharged from the hospital, and they're going, either back to home or they're going to a long-term care facility, right? How do we facilitate that process to make it a smooth transition? So like I can tell you just from experience and talking with families and some of the biggest, concerns that they have, of course, going from a acute care hospital to a long-term care or even to a rehabilitation center. Are the medications going to be available? What is, the schedule? What is, what services are going to be able to be provided? So like one of the biggest things we had talking to a family member, it was, a Friday afternoon. The family member had asked for them to wait to transfer the patient until Monday, because she was concerned about the patient being transferred over the weekend, and not having medications available. And they assured her, whoever was they, assured her that, there wouldn't be any issues with getting the medications. Everything would be great. And hence what happened. They ended up transferring the patient. And of course, with the, not, I don't even know how to say it. It just ended up being a disaster. Medications were not ready. The room was ready. Everything else was set up. But of course, we had, a delay in medications, which could result in a delay in care. So, and that can occur even in, if the patient was discharging from the hospital to to the home, making sure that, medications are either prescribed, whether it's a hard script or that they're called to the pharmacy to make sure that there is no delay in care regarding their medications. And so these are all things that when we look at those transitional care programs, how do we best, meet the needs of the clients and their families? The transitional care programs that involve home health, they have low and high intensity interventions. So low intensity interventions could be coaching, telephone follow-up, specific disease management, whereas your high intensity transitional care programs are designed for those that have complex or high risk health problems, and are usually provided by an advanced practice nurse. And so with the transitional care model, they usually have some cost savings, improvements in clinical and quality outcomes for clients that are receiving those interventions. So there's something. When we look at population health, it is the health status of a population of individuals, including the distribution of health status within the group. And so the field or emerging specialization of population health includes health status, determinants of the population's health and policies and interventions. And so we talked about triple aim, right? Population health has become more frequently, has been appearing more frequently in practice education, research, home or healthcare literature, and public press. So that is good too. That is a positive. we look at scope and standards of practice. Um, so we, talked about scope of practice. Um, nursing is an art and a science. All nurses will use the nursing process. So in ADPI, assessment, diagnose, plan, intervene, and evaluate. That is always your best, right? For whatever you do, you can use that nursing process. That is, where we, identify goals and how the goals are achieved and what interventions that we need to go back and address. um, the Omaha system the Omaha system, oh my goodness, I know we said we were going to talk about, it was initially developed to operationalize the nursing process and provide a practical, easily understood, computer compatible, quantifiable guide for daily use in a diverse community setting. Right now, the Omaha system is the only American Nurses Association recognized terminology developed inductively by and for practicing nurses in the community. So the goals of the Omaha system research were to develop structured and comprehensive system that could be both understood and used by members of various disciplines and to foster collaborative practice. It was designed to guide practice decisions, sort and document pertinent clinical or pertinent client data, provide a framework for agency-wide multidisciplinary clinic information management system that is capable of meeting the needs of practitioners, managers, and administrators. The components of the Omaha system were designed to be used together to be comprehensive, pretty simple, multi-dimensional. That is, if you've not seen the Omaha system, it is described very well in your book. Guidelines for nurses. So nursing practice is based on education, experience, and evidence. Within home health, because home health care and hospice and palliative care nurses work with clients and their families in their homes, right? We have to develop skills that, so we can conduct these home visits efficiently, effectively, and safely. So some of the skills should be a positive attitude about client-centered care, the nurse-client partnership, consumer engagement, critical thinking skills are a must. Effective care coordination requires familiarity with community resources. So what resources are there in the community that we can direct our clients to? Knowledge and skills involving medications, treatments, documentation, and equipment. Medications, pharmacology is one of those classes that I know a lot of people are like, oh, you have a little bit of PTSD from pharmacology, because it's a lot of information. But when you're giving medications, it is exceptionally important that you know what you're giving, why you're giving, how you're supposed to give it, when you're supposed to give it, right? Your 9 rights of medication administration. Technology is ever changing and improving, or let's just say changing. Sometimes it doesn't seem like it's an improvement, right? Making sure that you know how to use the equipment that the patients or your clients are, that they need. We had a situation, and I cannot remember what the situation, like I don't remember the piece of equipment that was the problem. But we were going to accept a client that had a specialized piece of medical equipment. I can't remember what it was. And nobody knew how to use the equipment. And so instead of providing education, they just denied the patient and let them go somewhere else, which is absolutely insane if you ask me, because most of the time, if you don't know how to use a piece of equipment, all you have to do is reach out to whoever the manufacturer is, and they can provide some education and training for staff to use that education. If you work in a bigger hospital system, right, there's a whole education department that is involved with, new equipment and are responsible for, the training. Never use a piece of equipment unless you know how to use it. That is going to be 100% key because you want to make sure that you're using it appropriately and that we're setting it up appropriately to avoid to avoid patient harm. Um, when people live in the community, there's no limits to, what their problems are. The interventions the nurse provide, their variety within the healthcare system as well as within the community settings. Again, that's why it's important for community health nurses to know what resources are available. Um, we look at, making sure that we are, providing a holistic approach, that we are engaging both the client and their family, that they are, a partnership with us when we're providing care, to provide the best outcomes, for our patients or clients. Another thing is OASIS. I don't know if anybody has ever heard of OASIS before. OASIS is the Outcomes and Assessment Information Set. It measures outcomes for quality improvement and client satisfaction with care. It's funded by Centers for Medicare and Medicaid Services, as well as the Robert J. Wood Foundation. And so it is required for use by Medicare certified home health agencies. So it's different. That's why I said earlier, like hospice doesn't have to worry about OASIS. But completing OASIS, it provides a systematic comparative measurement of client outcomes at 2 or more points in time. It helps to improve communication about their condition, among the, clinicians, the other agency staff. It improves reimbursements. It demonstrates improved cost-effective client outcomes for those clients that are within home health. It also provides data for calculating agencies' reimbursement for, particular clients' episodes. And again, it is a mandatory for CMS, home health care providers. And so I have some friends that work in home health and they said it's tedious. It is very tedious. It's a lot of documentation. However, it's, for, of course, the better of the, better for the care for reimbursement to make sure that the client is getting what the client is supposed to be receiving. And I'm going to touch back on medication management. As home health or, within, providing home health care, medication management is going to be a huge, important component of that. The goal is to assist the clients as well as the family to become independent and reliable in managing medication administration at home. We want to try to prevent medication, adverse drug events, side effects, avoid inadequate symptom control, as well as avoiding unnecessarily hospitalizations. Again, when we look at, the clientele that we'll deal with in home health, they often have chronic, complex medical conditions. They may even have, may be cognitively impaired. The more medications they are on, it increases their risk for drug-drug interactions. They may, experience side effects of the medications. And so, a lot of what, initially, especially is, one of the big things that home health nurse is going to have to do is to do that medication reconciliation. going through every single one of those medications, and, making sure, what's current, making sure that they're not outdated, that, they're taking their medications like they should be taking, and what education or how can we ensure that the client is taking their medication safely? Is it like one of those little pill boxes that say Monday through, Friday, or well, the 7 days a week, and or their medications are taken 2 or 3 times a day? Like, how can we assist them with keeping track of their medications, making sure that they're taking the medications like they should? Um, but polypharmacy is a huge issue, especially with some of your more complex chronic conditions, and especially with the elderly. And so making sure that when, medication reconciliation, if you remember from pharmacology, needs to be done at every point in the healthcare. So on admission to a facility, on transfer, even if it's within the facility. So if I'm going from the emergency room to the med surg unit, right, I need to have a medication and medication reconciliation. And then if I'm being discharged to home, discharged to another facility, wherever I'm being discharged to, another medication reconciliation needs to be completed. Any medication that is not necessarily needs to be discontinued, because, that just decreases the risk for those drug-drug interactions, side effects. Um, that's, usually the best thing that we can do. We also have to look at, what medications what over the counters are they taking when they're not in the hospital, what vitamins, what minerals, what supplementations, all of those things. We also need to provide, education and information. Um, it's not just always verbal. Make sure that they receive verbal education, that they receive written education, that the materials that we are giving are simple, they're understandable, and they are in the person's native language, right? So if you have a Spanish speaking client and you give them medication administration in English, then, that could be a potential issue. And this, I will forever stay ingrained in my head. ER was one of my favorite medical shows on TV. I loved ER, watched it from the beginning to the end. And there was an episode somewhere during that time frame. And I can't remember what the medication was. Okay, but whatever the medication was, it was supposed to it was to a child. It was supposed to be given 1 time a day, one pill 1 time a day. The directions were in English. And so instead of, where it said once, she thought she had to give 11. And so she basically overdosed the child because the directions were not in her native language. So it's super important that we're providing that information. If they can't read, and we still have plenty of people within the United States that cannot read or write, we need to provide, directions that are pictures, graphics, anything like that to help them to be, or to be safe with their medications. Also look at the use of your opioids. There's, with some of your chronic conditions, or even your post-surgical patients, they may be, discharged with opiate medications. We know that those are a danger, not only because of addiction, but safe administration. And so, home health agencies, they have policies on safe disposal of narcotics as well as other pharmaceutical products, right? And so that just makes sure that, we have proper disposal, not only for the client safety, for child safety, for environmental safety, right? But a lot of, which really surprised me is remember my daughter had to have surgery in her foot, And, the doctor called in for, I forget, I think it was oxycodone, the day before. So she went to the pharmacy to pick up her medication so she would have it post-op. And there was also a prescription for Narcan. So, I was like, why do you have a prescription for Narcan? And so because of, the potential for overdose risk, they had prescribed her Narcan just in case. And I thought that was rather interesting. And of course, now we know with the huge opioid epidemic and heroin epidemic within our country, right? You can go to the store now and you can buy Narcan. Everybody seems to be carrying Narcan with them. Regardless, biggest thing is to make sure that we are providing that medication reconciliation for our patients when they are transitioning, from one area of healthcare to the next. And so even within healthcare, there is still a chance for, errors as well as illegal and unethical behaviors, right? Like Medicare fraud, and abuse in home health, and hospice that include inappropriate use of services, excessive payments, kickbacks for referrals, um, billing for visits and medical supplies that were not authorized or provided. And so nurses are often confronted with legal and ethical issues regularly. So we need to be familiar with the living will, the power of attorney for healthcare, the DNR documents. We also, they need to be informed about local, state, and federal regulations that govern their profession and nursing license. So, it's always making sure that you are following professional, legal, and ethical standards when you're delivering care to clients. It's going to be your best thing. Just make sure that you are always, ethical when you are providing your care. And then the last little bit for this chapter, we'll talk about Healthy People 2030. So the national health objectives for 2030, reduce overall cancer death, increase proportion of cancer survivors who are living 5 years or longer after diagnosis, reduce the proportion of adults with chronic kidney disease, reduce inappropriate antibiotic use in outpatient settings, improve cardiovascular health in adults, and increase control of high blood pressure in adults, and reduce hip fractures among older adults. Other things that are pretty, up and coming, and some other resources that are out there. Telehealth is another big one that is making a big rise. It's the, using electronic information, medical devices, telecommunications. So, whether it's Zoom, the internet, streaming services, telephones, whatever it is. Telehealth includes triage and advice. We can do biometric telemonitoring. So like, think of like your, what are they called? Pacemaker checks. We can even measure vital signs, do some diagnostics. But there's a lot of telehealth opportunities that are arising. And then think of, your clients that live in, some of your more rural areas, where they may not have access to healthcare, directly, or they may not have, their closest clinic or hospital may be like, an hour away, and, they may not be able to have, or they may not have transportation, right? So what are some telehealth opportunities that we can use within those communities? All right, so that's it for my lecture on chapter, or for week 4. If you have any questions, feel free to reach out, and I will see you on Wednesday, sorry.